Welcome to the Hospital Medicine Unplugged podcast. As fellow physicians managing patients across the spectrum of acute and critical illness, we're constantly grappling with issues that, well, really define the quality and safety of our hospitals. And few issues are as endemic, costly, and frankly devastating to patient quality of life as the development of pressure injuries.
You're absolutely right. It's truly a bellwether for the systemic quality of care. And for us as hospitalists, it's an unrelenting focus area. The statistics alone are pretty stark.
They really are.
We're talking about a prevalence rate that swings dramatically. Anywhere from maybe 4% up to 23% in acute care settings. It really depends on the patient population, the hospital specialty focus.
And when you look at the sheer scale of the financial impact, the cost of treating these injuries nationally exceeds a staggering $17 billion annually. Just in the U.S., you realize pretty quickly this isn't just a clinical problem, it's an institutional imperative.
Exactly. And beyond the economics, which are huge, the functional decline, the chronic pain, the psychological toll on our patients, it's immense.
Absolutely. So our goal today is really to cut through some of the noise and synthesize the latest, most robust evidence. We're anchoring our discussion in the critical guidelines from the American College of Physicians, the ACP, and also the National Pressure Injury Advisory Panel, the NPIAP.
Right. We need to standardize our approach. Assessment, prevention, treatment protocols, all based on solid comparative effectiveness data. We need to move past, just institutional inertia or what we've always done.
Okay, so let's start at the very beginning then. Let's establish a common framework. We use terms like pressure injuries, pressure ulcers, sometimes decubitus ulcers interchangeably, but the current NPIAP terminology really favors pressure injury, right? To cover both intact and open skin damage.
Yes, that's the preferred term now. And if we look at the precise pathological definition...
Does you remind us?
Sure. It's defined as localized damage to the skin and often the underlying soft tissue too, typically occurring over bony prominences.
Right, the usual spots, sacrum, heels.
Exactly. And the mechanism is crucial. It's sustained pressure that means a continuous external load, often combined with shear or friction forces.
Ah, that combination.
Yeah, that pressure impairs local capillary blood flow, leading to tissue ischemia and eventually necrosis if it's not relieved.
That distinction between just pressure and shear is so vital, isn't it? Especially for patients who are, say, constantly slid up in bed or positioned poorly.
Absolutely. Shear is a major, often underestimated factor.
Yeah.
And the NPIAP staging system, which is really our global standard, ensures we're all speaking the same language.
Which is essential, not just for guiding treatment, but also for, precise documentation and tracking those quality metrics everyone's focused on now.
Definitely. Now, when we dissect the epidemiology, the trend is, well, it's worrying. The incidence is demonstrably rising.
Why is that?
It seems to be driven largely by demographic shifts, primarily the aging population, and also, frankly, the increasing complexity of patient comorbidities that we're now able to manage successfully in acute settings. These patients are surviving longer, but are more vulnerable.
Makes sense. The usual suspects for high risk are pretty obvious. Older adults, those with limited or complete immobility, patients needing complex critical care interventions, individuals with spinal cord injuries.
Right, but the reality is nearly any patient with a prolonged length of stay or significant systemic illness is potentially at risk. It's a broad net.
And the clinical consequences are what truly demand our attention, I think. A pressure injury isn't just a skin problem, is it? It's often a sign of systemic failure.
Precisely. It elevates the risk of serious, even life-threatening infections, things like osteomyelitis, sepsis. It necessitates substantially prolonged hospitalization stays.
Adds to the cost, adds to the burden.
Enormously. It inflicts chronic pain, and ultimately it contributes to increased mortality rates. It's not a minor issue.
It really sounds like an accelerator of decline in an already compromised patient. And this is why the ACP has made such a strong case for these structured, evidence-based, multi-component protocols.
Yes, multi-component. That's the key word. Single interventions, like just using a special mattress, they simply don't move the needle sufficiently on their own.
So we need a synchronized approach across the entire care continuum.
Exactly. And that directly impacts everything. Patient outcomes, hospital safety ratings, and yes, those increasingly scrutinized reimbursement metrics.
Okay. So if we're going to implement these multi-component protocols effectively, the prerequisite has to be accurate identification of risk, right?
Absolutely. Which leads us directly to the role of comprehensive risk assessment. Upon admission, yes, but also ongoing surveillance.
Now, many of us were trained on tools like the Braden scale or maybe the Norton scale. They've become pretty institutionalized. But the ACP looked critically at the effectiveness of these screening tools in actually reducing incidence. What did they find there?
Well, what's fascinating here, and maybe a bit counterintuitive, is the finding that no single standardized risk assessment tool, including the very widely used Braden scale, is definitively superior to expert clinical assessment alone for reducing incidence.
So the tool itself doesn't prevent the ulcer.
Not directly, no. This doesn't mean the tools are worthless. They're excellent for flagging patients who need to be placed on a specific protocol track for standardizing initial assessment. But the tool itself is really a baseline screen. It's not a substitute for the clinician's ongoing judgment. We still need to assess local tissue tolerance, the patient's systemic status, microenvironmental risk factors.
Well, that fundamentally changes how we should view the process, doesn't it? Assessment must be performed immediately upon admission, sure, but then repeated diligently whenever there's a significant shift in the patient's clinical status, maybe after major surgery, a transfer to the ICU, or initiating vasopressors, for example.
Absolutely. Continuous clinical vigilance based on these defined risk clusters is key.
Okay, let's talk about those clusters. What's the first major one?
The first cluster really involves mobility and age. Age itself is an independent risk factor, because of natural changes in skin structure, reduced subcutaneous padding.
Thinner skin, less cushion.
Exactly. And you couple that with limited or complete immobility patients who are truly bedridden or non-ambulatory, and you create, well, the perfect storm.
And the duration matters too.
Immensely. The sheer duration of hospitalization or ICU stay compounds the risk. Tissue damage is cumulative over time.
Okay, moving beyond the sort of mechanical aspects, what about systemic factors? Perfusion and comorbidity seem critical for us as hospitalists.
Hugely critical. Conditions like poorly controlled diabetes, advanced cardiovascular disease, chronic renal failure, these dramatically impaired tissue healing and resilience. The tissue just isn't as strong to begin with.
And in the acute setting, what about perfusion specifically?
We absolutely must talk about impaired perfusion in the acute setting. Any episode of hypotension or, the necessary but risky use of vasopressors.
Which shunt blood centrally.
Precisely. They're designed to save vital organs by shunting blood centrally. But that can sacrifice peripheral tissue perfusion. That low flow state effectively starves the tissue over bony prominences. It makes it highly susceptible to injury, even under relatively minor pressure loads that normally wouldn't cause a problem.
That's a really important point for ICU care. What about nutritional status? That's another major systemic variable we can't overlook.
No, we can't. Tissue repair is a highly metabolic process. It requires building blocks and energy. Poor nutritional status compromises the structural integrity of the skin and the body's fundamental repair capabilities.
Are there specific markers we should look for?
Well, we often cite low albumin levels or anemia. Now, albumin itself is probably a poor marker for acute malnutrition, but is a good marker for the general systemic inflammatory state and overall protein deficit. And that correlates strongly with a diminished ability to withstand pressure and recover from injury. We have to view these deficits as critical indicators that a patient just can't launch an adequate immune or proliferative healing response.
Makes sense. And then there's the mechanical and environmental cluster. This focuses more on localized conditions.
Right. Things like incontinence, both urinary and fecal. This leads to moisture-associated skin damage, sometimes called MASD or maceration. That moisture drastically lowers the skin's threshold for injury from pressure or friction.
And we have to recognize the ubiquitous risks of friction and shear, which we mentioned earlier.
Yes, they are frequently overlooked mechanisms of injury, often occurring during patient transfers, repositioning, or even just when a patient slides down in a chair or bed. Shear forces deform the deep tissue structures, damaging capillaries right at the tissue-bone interface, sometimes even before the skin itself breaks down visibly.
We also see heightened risk at the extremes of body habitus, don't we?
We do, both very low BMI, where there's minimal soft tissue padding over bony areas, and also high BMI, measured in kilograms per meter squared. With high BMI, just managing positioning and effectively offloading pressure points becomes geometrically challenging.
True. And something relevant to nearly every patient we manage. Medical devices.
Oh, absolutely. Nasogastric tubes, oxygen tubing, indwelling catheters, ostomy devices. They all create predictable, localized pressure points. These device-related pressure injuries, or DRPIs, are increasingly common, and they really demand preemptive surveillance. We need to look under and around devices regularly.
And tying into that surveillance, we also have procedural risks, things like sedation, mechanical ventilation.
And particularly long surgical procedures, where the patient is immobilized on a relatively hard operating table surface for several hours. These all mandate a sky-high level of surveillance intensity immediately post-procedure. Recognizing these cluster factors really dictates our proactive strategy.
Okay, so that covers risk identification. Now, moving to prevention, you mentioned the data strongly champions these multi-component protocols.
Yes, it's not just putting a special mattress on the bed, though that's part of it. It's a whole system of aligned interventions. This combined approach, things like structured staff education, meticulous skincare protocols, consistent repositioning, has proven exponentially more effective than just doing one single thing.
And a multi-component approach inherently requires multidisciplinary alignment, doesn't it?
It absolutely does. This means active participation from wound care specialists, sure, but also engaging physical therapy early for mobilization strategies. And ensuring nutrition consults are activated when those metabolic deficits, like low albumin or poor intake, are identified. Everyone has to operate from the same protocol playbook.
So let's talk specifics within that protocol. Support services are often the most significant institutional investment. What does the ACP say about them for prevention?
Okay, for prevention, the ACP makes a clear evidence-based distinction. They recommend advanced static mattresses or specialized overlays. The data shows these are superior to standard hospital mattresses for preventing new ulcer development in high-risk patients.
Now, this is where we need to address a common institutional practice, which is defaulting quickly to dynamic surfaces, right? Like alternating air or low air loss mattresses.
Yes, that happens a lot.
But if we follow the comparative effectiveness data strictly for prevention, what did the ACP note about those dynamic surfaces?
Yeah, this is a critical point for resource allocation. The ACP noted that these dynamic surfaces, alternating air, low air loss, actually lack sufficient evidence to prove clear superiority over the advanced static surfaces, specifically for the purpose of prevention.
So spending a lot on dynamic beds just for prevention might not be the most evidence-based first step.
Not necessarily. Based on the current comparative data, the priority, according to the ACP guidelines, should be implementing high-quality static overlays or mattresses as the evidence-based baseline for most high-risk patients identified. Dynamic surfaces may have a role later or for treatment, but not as the universal preventive default.
Okay, that's a very important distinction. Now, beyond the surface itself, regular repositioning remains fundamental. We always hear turn every 2 hours. Is that still the rule?
Well, it's the classic rule, but the optimal interval is not a universal mandate anymore. It really must be individualized.
How so?
A high-risk patient on, say, a standard surface might indeed require more aggressive turning, maybe even more often than Q2 hours. But a perhaps slightly lower risk patient on an advanced static mattress might tolerate a longer interval, maybe Q3 or Q4 hours, provided there is adequate skin assessment in between turns. It's a decision that requires clinical tailoring based on the patient, the surface, and skin tolerance.
Got it. And complementing the offloading strategies is comprehensive skincare.
Yes. This includes consistent, gentle hygiene, avoiding harsh soaps, using moisturizing products to maintain skin barrier integrity, and the increasingly recognized use of prophylactic dressings.
Prophylactic dressings. Can you elaborate on those? Which ones offer the most compelling evidence for prevention?
Yeah, this is an interesting development. We have very good data supporting the targeted use of specific silicone-based dressings, usually applied over high-risk, vulnerable areas.
Like where specifically?
Specifically the sacral area and the heels. Those are the hot spots. And the mechanism of action here is key. These dressings seem to act as external friction and shear reducers. They help distribute those microstresses that contribute to deep tissue damage even before the skin breaks.
So you're mitigating the very forces that cause the deep injury in the first place.
Exactly. This is a very targeted, evidence-based intervention that really should be standardized in high-risk prevention protocols.
That makes perfect sense. Okay, so we've covered risk and prevention. Now let's turn to the necessary language of management, the NPI-AP classification system. This staging system really dictates our treatment decisions and, to some extent, prognostication.
Absolutely. Understanding the visual appearance of each stage is paramount for communication and care planning. Stage 1 is the beginning of the problem, often missed if you're not looking carefully. It's defined as non-blanchable erythema of intact skin.
Intact skin is key there.
Crucially, yes. The skin is unbroken, the color is persistent, maybe deep red or purple, and it doesn't blanch with pressure. Often the patient might report localized changes in sensation, temperature feeling warmer or cooler than the surrounding skin, or maybe a difference in firmness.
Okay. And if that persistent redness progresses?
If that persistent erythema moves past the point of just skin color and temperature changes, we reach stage 2. This is defined as partial thickness skin loss with exposed dermis. So the top layer is gone.
What does that look like?
The wound bed itself is viable, usually appearing pink or red and moist. Clinically, you might see this present as an intact serum-filled blister, or perhaps one that is just ruptured. The key differentiator for stage 2 is that you are only seeing damage down to the dermis. Deeper structures, fat, muscle, are specifically not visible.
And we have to be careful to differentiate stage 2 from moisture-associated skin damage, right? MASD.
Oh, absolutely critical distinction. Stage 2 is caused by pressure or shear, usually looks like a discrete ulcer or blister. MASD is related to chemical irritation from moisture, like urine or stool. It often looks more diffuse, shallow, maybe irregular in shape, and often has redness around it. Misclassification leads to inappropriate treatment choices.
Good point. Okay, stage 3 marks a significant clinical progression. What defines that?
Stage 3 is full thickness skin loss. Here, adipose tissue or subcutaneous fat is visible in the ulcer bed. You can see the yellowish globular fat tissue. We might start seeing granulation tissue, which is that beefy red, healthy-looking tissue that's encouraging, but we also commonly see epibole.
Epibole.
Yeah, that's the term for rolled or curled edges of the wound where the epidermis kind of curls under. It can slow down healing.
Yeah.
Undermining tunneling, where the injury creates sort of cave or tract extending underneath the intact surrounding skin, may also be present. But the strict rule for stage 3 is that fascia, muscle, tendon, or bone are not exposed. You only see fat.
Okay, so if those deeper structures are exposed or directly palpable,
then we are unequivocally in stage 4 territory. This is full thickness, skin and tissue loss.
yeah,
You have visible or directly palpable fascia, muscle, tendon, ligament, cartilage, or even bone within the wound bed. These injuries often present with extensive undermining and tunneling, reflecting the massive, deep tissue destruction that has occurred. Stage 4 wounds almost always require the highest level of care, often including surgical intervention.
Now, beyond those 4 standard stages, there are 2 other challenging classifications that demand accurate documentation because they significantly alter the immediate management plan. First, the unstageable pressure injury.
Right. An unstageable injury signifies obscured full-thickness skin and tissue loss. The problem is, the actual depth of the wound, whether it's truly a stage 3 or a stage 4 underneath, cannot be determined.
Why?
Because the wound bed is covered by either slough, which is typically that yellow, tan, gray, or beige necrotic tissue, often stringy, or it's covered by eschar, which is the dark brown or black, hardened, dead tissue, like a scab but thicker and adherent. You simply have to remove that slough or eschar to bride the wound before you can accurately stage the true depth of the injury underneath.
Okay, so unstageable means needs debridement to stage. What's the second challenging classification?
That's the deep tissue pressure injury, or DTPI. This is often initially diagnosed when the skin is still intact, or maybe there's a blood-filled blister. It presents as a persistent, non-blanchable, deep red, maroon, or purple discoloration. This color strongly suggests significant damage to the underlying soft tissue and muscle layers from intense and/or prolonged pressure or shear.
So the surface might look okay-ish, but there's trouble brewing underneath.
Exactly. The clinical challenge with DTPIs is their unpredictable and often explosive evolution. They can deteriorate dramatically over a very short period, sometimes just hours, to reveal the full, extensive extent of the underlying necrosis, often becoming a stage 3 or 4 ulcer very quickly. This mandates extreme surveillance and aggressive preventative offloading, even when that skin barrier is initially intact. Don't be falsely reassured by intact purple skin.
Wow, okay. That systematic staging really brings us to our final, and I think most action-oriented section, evidence-based wound treatment and management. Once an injury is established, how does the evidence guide our selection of advanced support surfaces for treatment? Is it different from prevention?
Yes, here the data for treatment is somewhat different from the data for prevention. For treatment, the ACP gives a stronger recommendation for the use of air-fluidized beds.
Why the stronger recommendation here?
Because studies specifically looking at treatment demonstrated their superiority over standard hospital beds in reducing ulcer size. The mechanism involves the air-fluidized media. It's like tiny beads flowing with air, which minimizes shear forces and creates this near-uniform pressure distribution across the wound bed. This seems to optimize local circulation and promote healing in established wounds.
So air-fluidized beds are costly, yes, but the data suggests they should be prioritized for patients with established, perhaps higher stage injuries, specifically to accelerate healing.
That seems to be where the evidence points for treatment, yes.
Okay, let's talk about nutrition again, but this time specifically as a therapeutic tool for healing existing wounds.
Right. For treatment, we move from general prevention strategies to more targeted intervention. Protein or specific amino acid supplementation is recommended by the ACP.
But with a caveat, right?
Yes, a significant caveat. It's recommended only to improve healing rates in patients who have documented malnutrition or deficiency. We need that documentation of a deficit low-prealbumin, inadequate intake, significant weight loss. While certain supplements like arginine or glutamine may theoretically aid tissue synthesis, routine, broad-spectrum supplementation in a patient who is already well-nourished consistently lacks evidence of benefit for wound healing. We must be targeted with our nutritional optimization for treatment.
Good clarification. Okay, moving to the local wound care itself, the choice of dressing is paramount. You mentioned earlier we're aiming for a moist wound environment.
Yes, maintaining a moist wound environment is the consistent goal across all stages of healing. It facilitates cell migration and tissue formation. The old let it air out approach is definitely out.
So how do specific dressing types stack up against each other based on evidence? What about standard gauze?
When comparing standard practice gauze against more modern products, the evidence is pretty clear. Hydrocolloid dressings are preferred over simple gauze.
Why is that?
Hydrocolloids are known for their ability to maintain that moist environment effectively, and they can absorb low to moderate amounts of exudate. Studies show they lead to a better reduction in overall wound size compared to gauze. Gauze, on the other hand, tends to dry out quickly, can stick to the wound bed, and potentially strip away newly formed tissue upon removal.
Okay, so hydrocolloids over gauze. What about the choice between the common advanced dressing types, like hydrocolloids versus, say, foam dressings?
That's a good question. If you look at hydrocolloid versus foam dressings, and foams are excellent for absorbing higher volumes of exudate while still maintaining moisture, the evidence suggests they're roughly equivalent for achieving rates of complete healing.
So similar outcomes in the end?
For complete healing rates, yes, often similar. So the clinical decision between them often boils down to practical factors. The volume of exudate the wound is producing, the location of the wound, some dressings can form better, and sometimes institutional cost-effectiveness and formulary availability.
But you mentioned earlier there is at least one clear contraindication in dressings we need to recognize.
Yes. The ACP specifically advises against the use of dextranomer paste. This product, which was designed to absorb exudate, has been shown in controlled trials to be inferior to other local wound care methods. Its use is not supported by comparative effectiveness data and should generally be avoided for pressure injuries.
Good to know. Now, wound bed preparation is the prerequisite for all advanced healing strategies. This requires debridement, the removal of that devitalized tissue like Slough and Escher. What methods are available, and does the evidence favor one method over another for actually improving healing rates?
We have several methods available. There's surgical debridement, often done at the bedside or in the OR, which is rapid and complete. There's enzymatic debridement, using topical agents that break down necrotic tissue. And there's autolytic debridement, which uses the body's own enzymes under an inclusive, moisture-retentive dressing. Now, while debridement is absolutely essential, you need to remove that dead tissue to minimize bacterial burden, reduce infection risk, and provide a clean base for new tissue growth. Surprisingly, the evidence does not clearly favor one specific method over another when you measure the ultimate rates of complete healing.
Really? So the speed might differ, but the end result is similar.
In terms of complete healing rates, the evidence suggests yes. So the clinical decision often focuses on other factors: the urgency, surgical is fastest, the amount of necrotic tissue, patient stability, pain control, and available resources. The main goal is getting the dead tissue out, and the specific method is often secondary to achieving that outcome effectively.
Okay. And alongside debridement, meticulous wound cleansing is essential.
Precisely. The recommendation here is to use non-cytotoxic solutions. Normal saline is usually the standard. We must avoid strong agents like hydrogen peroxide or povidone iodine directly in the wound bed for routine cleansing, as they might damage the fragile, viable cells needed for healing. The goal is gentle cleansing to reduce bacterial burden and prevent biofilm formation, which is a major barrier to healing, without harming healthy tissue.
Okay, finally, let's turn to adjunctive therapies. This is often where we see maybe a lot of hype and sometimes less concrete data. Where do modalities like negative pressure wound therapy or electrical stimulation fit into the evidence-based algorithm?
You're right, this area needs careful interpretation. Most adjunctive modalities, including things like electromagnetic therapy, therapeutic ultrasound, and laser therapy, have demonstrated variable or quite limited benefit when rigorously compared to standard wound care controls in pressure injury studies. They should generally be considered on a case-by-case basis, perhaps for refractory ulcers that aren't responding to standard care, but they are definitely not first-line interventions supported by broad, strong evidence for routine use.
What about negative pressure wound therapy, NPWT, or wound VACs? That seems like a widely used modality, particularly around surgical settings.
NPWT is definitely common, yes. But for pressure injury specifically, its superiority over standard advanced dressings for improving healing rates is actually not consistently proven in the broad literature for all pressure injuries. It certainly has specific utility, particularly for managing wounds with very large volumes of exudate or maybe preparing a wound bed for surgical flap coverage. But it's not necessarily a magic bullet for every pressure ulcer, despite its prevalence.
Interesting. Now, you mentioned electrical stimulation earlier as potentially having maybe a niche benefit.
Yes, E-stim is an interesting case. Some studies suggest electrical stimulation may accelerate the velocity of wound healing, meaning the rate at which the wound area reduces per week. But importantly, it generally does not seem to improve the overall rates of complete healing compared to control groups receiving standard care. Furthermore, it carries a definite risk of skin irritation, which can be problematic, particularly in our frail, elderly patient population. So it requires a careful risk-benefit analysis before deployment, and it's not a standard recommendation.
Okay. So for those really advanced stage 4 or chronic non-healing ulcers, we often do require surgical intervention. Standard surgical practice involves aggressive, thorough debridement, often followed by flap coverage to bring in vascularized, healthy tissue. What is the key complication we must anticipate and manage post-surgery?
By far, the most common surgical complication is wound dehiscence, GEISS. That's where the wound edges separate or the flap fails to take hold and pulls apart. This risk is notably high, especially in complex cases that required underlying bone removal, osteomyelitis treatment, or in high-tension areas like ischial ulcers, those buttock ulcers that are subjected to enormous pressure when a patient is sitting or transferring. Managing these patients requires meticulous postoperative care, especially strict offloading and immobilization protocols.
Right, protecting that flap is critical. So, bringing all this evidence together for our hospitalist listeners, this deep dive has really revealed, I think, a clear dichotomy between our strategies for prevention versus treatment.
Absolutely. The foundational takeaway is really a dual mandate, isn't it? Prevention hinges on rigorous, comprehensive risk factor mitigation. That means utilizing targeted nutritional supplementation, but only when deficits are proven. It means individualizing those repositioning schedules based on the patient and the surface, and implementing advanced static support surface as the evidence-based baseline for prevention.
Whereas when we shift to treating established, perhaps high-stage injuries, the evidence pushes us toward different tools, maybe air-fluidized beds to accelerate ulcer reduction, definitely combined with targeted protein optimization if needed, and the diligent use of appropriate moist dressings like hydrocolloid or foam.
While actively avoiding contraindicated therapies like that dextranomurpase we mentioned, it's really a transition from mitigating risk factors proactively to actively maximizing the regenerative potential once an injury has occurred.
Well put. Given the massive cost burden, the significant morbidity, and the complex nature of our aging patient population, we absolutely must consider the systemic impact of this problem. We've established that relying solely on a risk assessment tool score, like the Braden scale, is insufficient for prevention. So, we'll leave you, our listeners, with this provocative thought. In your specific practice setting, recognizing that system-wide change is the ultimate goal, what specific, measurable quality metric initiative offers the greatest practical return on investment? Could it be mandatory, standardized staff education across all shifts on prevention bundles? Maybe universal adoption of prophylactic silicone dressings for sacrum and heels in all high-risk admissions? Or perhaps focusing resources on ensuring timely nutritional consults? Consider what offers the greatest impact on patient outcomes and hospital resources at your institution. Because the real clinical victory lies in ensuring that those evidence-based multi-component protocols are applied consistently, reliably by every discipline involved, from the moment a high-risk patient is admitted right through until their eventual discharge.